I'm in New Orleans at University Medical Center. I have two burn partners, Dr. Jeff Carter and Dr. Jonathan Shane. We are all 100% burn all the time, although we are a level 1 trauma center, so I take a personal interest in limb salvage and sometimes do those cases with my husband, who's an orthopedic trauma surgeon. We see a high rate of concomitant trauma at our center. To about 1 in 5 of our burn patients has concomitant trauma. Whenever I can send a patient for burn surgery, I always have to warn them that the thing that's going to hurt the most after surgery is their donor site. In fact, if you're not familiar, a lot of our patients will wake up in the post-anesthesia care unit and say, oh my gosh, they operated on the wrong thing because it's the donor site that hurts. It's not the wound that hurts. And that's very counterintuitive. We've been looking for a solution to that for a long time. I think our whole world has, the whole burn world. And so just hearing about this was really exciting. So once we got our hands on some and tried it on one patient, it was quite obvious that it was making a major difference. We take our donor in the normal way that we always do with a dermatome. If we are using skin cell suspension autograft or RECELL for the case, we often spray our donor sites with RECELL. We then apply the PainGuard to the site, and then we do our normal donor site care, which at our institution is just Xeroform. We usually do a layer of Telfa Clear after that, so then our gauze won't stick as much to the Xeroform for secondary dressing changes. But Telfa Clear, gauze, and an ACE wrap in the usual fashion. I will say that this is the first product that I've been excited about in regards to donor sites. First and foremost, what the patient cares about is how much it hurts, and that can be debilitating. And so I think to that end, this is the first time that I've thought, man, I really think that a product made a difference in donor sites.
So I currently practice at a level 1 trauma center in Las Vegas, Nevada. My practice consists of acute care surgery, trauma surgery, as well as burn surgery. I do treat many of our chronic and acute wounds in this hospital as well on an outpatient basis. So one of my patients that I used Pelashield early on and was a limb salvage patient. This patient had come in with acute on chronic wounds that evolved to full thickness over the course of his hospitalization, and unfortunately did not get the source control that he required for probably a month. In the ICU at the bedside during one of his vac changes, we said, okay, let's try this. If this doesn't work, we're probably going to have to amputate. And so we laid down a layer of Pelashield right onto the wounds themselves and applied a wound vac over top and gave it about 3 to 5 days and took the wound vacs off and essentially saw finally some beefy red tissue, especially on that right leg. It was definitely not the end of his course, but that was the turning point in realizing that we were able to salvage these limbs. And obviously his sister was very grateful. He ended up being weaned from the vent and was very grateful himself. I think in addition to the surgical source control, having some type of local mechanism for source control from an antimicrobial standpoint made the difference.